Hi, everybody. Thank you so much to all of you for being here on a Saturday and those of you who are online. I also just wanted to take a second to say that I had the great pleasure and privilege of knowing Val Guild very well. And thanks to John, I was invited within a day of having become an attending to go to this Women in Melanoma symposium, which is where all of us female academic oncologists, dermatologists, surgeons, very focused on melanoma, meet up once a year. And actually, this will be I believe, my 8th year going. It's really one of the best meetings of the year. We get together and we talk about patient-facing issues. So I am one of the melanoma medical oncologists here. And today we'll be talking about whether or not we can predict who will respond to immunotherapy. That's really the burning question, I think. It's one of the many burning questions that keeps, certainly I know I speak for Dr. Kirkwood and my partners and I, that keeps us up at night. So historically speaking, of course, cancer is not a new problem. This is not a new plight. But if you were somebody living in 1450, your average life expectancy was probably to about 28. And so actually you'd be geriatric at 28, and we are now living longer and longer. And so this is why we are seeing cancer more and more. In fact, the median age of, or I should say rather, the average age of melanoma diagnosis in the US is 65. So over half of patients are over 65 when they're diagnosed. So I think that really drives home what I was referencing. If I really like history, so I look at everything from a historical perspective, but there are mentions of breast cancer tumors being cut out. Of course, they didn't have the language for this. As far back as 1600 BC in hieroglyphs. And so what we have done now, it seems, medieval, even though this is what we're doing until quite recently, you'd cut it out, you'd give chemotherapy, which acts functionally as a nuke, killing good cells, bad cells, all cells. We then had the rise of radiotherapy, various chemotherapies, and we have become slowly, but also in a way very quickly, because we've picked up speed, much more sophisticated in how we care for our patients. The old paradigm was that you would directly target the tumor, cut it out, zap it with radiation, hit it with chemotherapy. The new paradigm is we're not really bothered, if you will, by the tumor. We're bothered by how can we switch on the patient's own immune system, because this is something that the gentleman in front of me referenced very correctly. Cancer in general and melanoma in particular, I think we could successfully argue is fundamentally a failure of the immune system. How did the cancer get to grow in the first place? How did it come to equilibrium with the immune system? And then how did it manage to escape and evade the immune system and spread to the brain, lung, liver, etc.? It's because the immune system did not see what was going on. And so what we all try to do is understand how we can overcome that. When I was training, when I was in medical school now 20 years ago, we would measure life expectancy for a patient with advanced melanoma in the order of months. It was a very depressing field. And this is why I have to really tip my hat to my mentor and now dear friend, Dr. Kirkwood, who stuck it out. I came into this really because I was interested in immunotherapy 10, 15 years ago. And so I've seen the sea change. But I'm standing on the shoulders, as are all of us, of people who stuck with it for decades and decades when we didn't know what was going to happen. There was, the idea of immunotherapy in melanoma. Now, as Dr. Kirkwood said, we really are leading the field. The first immunotherapy was approved in melanoma. First combination in melanoma, without exception, most recently, Opdualag. That's the first time we're hitting a target called LAG3, approved in melanoma. First time we used immunotherapy in stage 3, melanoma. First time we used it in stage 2, melanoma. You see where this is going. But for a long time, that's really not how it was. And now, when we see a patient diagnosed with stage 4 melanoma, and we see at least 5, 6, 7 new patients a week, we can tell them that if we treat them with immunotherapy A plus B, their odds of being alive at 7.5 years now are 48%. That is astounding. And I don't think in my lifetime that'll ever get old, because I remember very clearly how it was before. The thing is that we have to be very careful not to say, oh, great, we think we're curing 48% of patients. The real question is, how are we failing the balance of 52%? Those who have not responded to therapy, that's what we're now focused on, which is to say we're not patting ourselves on the back, right? There's still a huge amount of work to be done, which is why we're all here. What we're really interested in understanding is why some patients respond to immunotherapy and others do not. And what I want to do here is really try and set the stage, because I don't want to get lost in the weeds of the jargon, but I want to make sure that what I'm saying makes sense. When I say, can we predict who's going to respond to treatment? What I'm really asking is, do we have a predictive biomarker? Biomarkers are basically different things: lab values, microscopic findings, imaging findings, proteins, anything you want can be a biomarker. A prognostic biomarker will tell us how the patient will do, irrespective of treatment. For example, we know that if a patient's melanoma goes to the brain, that's generally not a good thing, even though we have very good treatments now. A predictive biomarker predicts whether or not a patient will respond to therapy. So that's really a foundational concept for the rest of my talk, not to be gibberish. One of the talks that came in, one of the questions that came in very early this morning was, if a patient has a BRAF mutation, are they more likely to respond to therapy? The answer is a resounding yes. And I put this in here because I want to say that the BRAF mutation, which is found in about half, 40% to 50% of cutaneous melanoma patients, is actually a very robust and an excellent predictive biomarker. I can very confidently say that if a patient has a BRAF V600E or K mutation, they will respond to BRAF targeted therapy. So that's a good example. And there are multiple combinations of BRAF and MEK inhibitors, which I won't get into because that's not the scope of our discussion. But the point I want to make is that for BRAF mutant patients, we have a first-rate predictive biomarker. For immunotherapy, not so much. And that's what we're going to talk about today. Why is a predictive biomarker so important? This past week in my clinic alone, we probably had 7, 8, if not more, patients come in and start treatment. Some are starting for stage 2, some are starting for stage 3, some are starting for stage 4. And some are starting a new treatment for stage 4 that did not respond to the frontline treatment, the first thing that I thought was best for that patient. The problem is, if you're one of me or one of Dr. Kirkwood, we go in really not knowing, and I want to be clear, I'm speaking here about immunotherapy. We go in not knowing who's going to respond to treatment and who isn't. In a way, we are going blind. I know some patients are going to have an amazing response. And I know that for some patients, the treatment is not going to touch them. Who's who? I have no idea. And that's what we're trying to figure out. The reason it would be very important to have a predictive biomarker is that we can tell early on who is not going to benefit, and we can spare them toxicity. Immunotherapy, while generally well tolerated, certainly is not sugar water. And there are serious and rarely life-threatening toxicities associated with it. We would be able to spare patients whom we know have low likelihood of benefiting from treatment the toxicities, the adverse effects of immunotherapy. Never mind the strain on the healthcare system itself. And it would allow me as a physician to make a very informed decision up front and pivot to a different line of therapy. We know, for example, that regardless of I'll rephrase. We know that patients who have a BRAF mutation do better if we start with immunotherapy. But maybe if I had a predictive biomarker and I knew that patient X was not going to benefit, I would ignore that data. And I would start the patient on immunotherapy. On targeted therapy, on BRAF MEK inhibitors rather than immunotherapy. Now with the approval of the very first cell therapy in solid tumors, also in melanoma, might I add, I might choose to do that for a patient before putting them through the rigmarole of immunotherapy if I know it's not going to work. And yet, as of today, we do not yet have a predictive biomarker that is sufficiently robust to inform our decision-making. Now, to have a predictive biomarker, ideally, you would be meeting several criteria. You would have high accuracy. This is obviously very important because we're making huge decisions about patients' treatment on its basis. Minimally invasive. Obviously, we don't want to be biopsying a patient again and again and again in their tumor. If you were very fortunate, you would identify one in the peripheral blood, for example, something that you can scale, a biomarker that is not just done at a center of excellence like this one, but something that can be done in the community, something that somebody could do in North Dakota as well as they could do in Beijing, and highly reproducible, i.e. validated, something you can depend on. This is a very exhaustive review that we published recently in Nature, looking at all of the different biomarkers that have been evaluated in the context of immunotherapy in particular. And I really don't want to take us completely off track, but I wanted to say that even though these are not ready for prime time, in the sense that you will not see us using these to determine your treatment, typically in clinic, there are some that we are using very, very frequently. One is circulating tumor DNA. Certainly, I know in my clinic and Dr. Kirkwood's, because we overlap once a week, this is something we're sending all the time. We look at the levels of circulating tumor DNA to get a sense of, is it going up or down? And certainly I won't change therapy accordingly, but it gives me a very good sense of whether or not a patient may be responding. The way I put it to the patient is it's an additional data point. How you're doing your scan, how much of your DNA from the tumor is circulating in your bloodstream, all of this together helps me make the most informed decision I can. Something my lab is very interested in is immunohistochemistry and immunofluorescence, and I'll come to that very shortly. But there are a lot of different biomarker technologies under evaluation. So PD-1 is the receptor that sits on T cells, your immune cells, and it binds to PD-L1, which is expressed on tumor cells, such as melanoma. And for very obvious reasons, it's probably not a leap to imagine why in the beginning we all thought PD-L1 was going to be a gangbusters biomarker. We were absolutely wrong. This is a figure that you can see from the pivotal paper that led to the approval of nivolumab and ipilimumab. And the long and the short of it is you can see that whether or not a patient had PD-L1 did not definitively tell us whether or not they were going to benefit from treatment. You can have low PD-L1 in your tumor and have great benefit. You can have low PD-L1 in your tumor and have no benefit. And so it doesn't steer us, which frankly surprised me 10 years ago now. And this is also true of every other one, by the way. This is true of CTLA-4. This is true of LAG-3, most recently with the approval of relatlimab, nivolumab, or Opdualag. There is nothing in the tumor itself that we test to determine whether or not a patient should receive immunotherapy X, Y, or Z. We make our decision based on the subtype of the melanoma, based on the extent of the disease, based on how the patient is doing. But you probably know we're actually not checking PD-L1 in the tumor. I don't care, because whether it's high or low, as far as I know, immunotherapy is still the best treatment, and this is what I'm going to utilize until I have a biomarker sufficiently robust to tell me otherwise. So we use immunotherapy now, even though melanoma obviously was the first place we use it in a lot of diseases. And in fact, immunotherapy is the first time that we saw what we call tumor agnostic approvals, meaning regardless of what type the tumor is, if there is a certain biomarker, there have been these clinical trials done whereby FDA has said, for example, if a tumor has a high tumor mutation burden, that means that the tumor is very heavily mutated. This is something we test in the lab. And if a tumor is super heavily mutated, more than 10 mutations per megabase of DNA, you can use immunotherapy. Whether it's pancreatic cancer, brain cancer, whatever, it doesn't matter. This is very particular to immunotherapy, but I want to say even in this context, and there's a lot of literature about this, it is still not an ironclad biomarker. Having a high TMB or tumor mutation burden absolutely does not guarantee you a response to immunotherapy. Another biomarker that we look at is microsatellite status, which is basically a long-winded way of saying how the DNA repair mechanisms work. So all of us, as we divide our cells, DNA machinery makes mistakes. This is normal. The question is, can your immune system clean it up or not? So for patients who have microsatellite unstable tumors that have a lot of mutations, this is another place where regardless of the tumor type, you use immunotherapy. Again, this is another place where microsatellite status is not an ironclad biomarker. All of that to say there's no always or never. We also use immunotherapy much earlier. When I was starting, we were doing the clinical trials, we were running the clinical trials of immunotherapy in stage 4. We then ran the clinical trials of immunotherapy in stage 3, and we showed very clearly that there was a benefit to the risk of recurrence. Most recently, we led the trials here for immunotherapy in stage 2. Again, we showed that there's a significant reduction in the rate of recurrence. However, and I say this to every patient, you can get immunotherapy for stage 2 or 3, and your melanoma might still come back. We don't know who's who. Similarly, you could opt not to have any immunotherapy for stage 2 or 3, and it could never come back. So when we're talking about these clinical trials, we're talking in averages. We're saying in an average population of so many hundred patients, those who got immunotherapy did better than those who didn't get immunotherapy. But again, we still don't have a way of predicting who's who. And this is in the context of metastatic disease, stage 4, but also earlier stage 2 and 3. You can appreciate as well in the adjuvant setting, meaning when you're giving immunotherapy as a cleanup job after surgery for stage 2 or 3, a predictive biomarker, I would argue, is even fundamentally more important because the risk of toxicity, while always a concern, regardless of the stage, I would argue is even more of a concern in a patient who's potentially cured by surgery alone. So this is a place where we really are in dire need of a biomarker. There are multiple biomarkers under investigation, and as I alluded to, ideally, this would be something coming from the peripheral blood. This was a very nice review that was recently published. They looked at hundreds of studies and then put together data from about 140 of them. And this is basically the sum total of all of the things that are hinting in one direction or the other. But again, none of this is being utilized in routine practice. This is still very firmly in the realm of research. We know that when looking for biomarkers for reasons that I mentioned, we think that peripheral blood is of particular interest, and we've become increasingly focused on glycosylation. So glycosylation basically means that the protein, protein has this sugar moiety or sugar molecule sitting on it. And about 70% of proteins are glycosylated. And so this is data that we presented at a meeting very recently. But the reason I think glycoproteins are of particular interest is that there's simply so many of them. And you can appreciate that by expanding the repertoire of whatever you're looking at, you may have a higher chance of alighting on something of significance. So this is basically to show that we developed this, this platform has been developed by this company with whom we've been working very closely. And you can run this assay on 100 microliters, a tiny, tiny bit of blood from an individual patient. And because you're generating so much data by looking at glycoproteins, this is where the AI part becomes very critical so that you can actually analyze this huge amount of data that you're generating. And what was done was basically we assessed close to 600 biomarkers. And without getting into the weeds about it, I'll just say that we took a very small amount of blood from patients before they started any of their immunotherapy treatment. And these were patients with stage 4 melanoma. And we basically looked at multiple iterations and went on to develop a particular signature. And when I say signature, I mean we identified a number of glycoproteins, looking at proteins in the blood, looking at sugars on proteins in the blood, that when you put them together, could help us predict who was going to benefit from immunotherapy and who wasn't. And this was started off by looking at a discovery cohort. So we had blood from 202 patients, and you basically break down the cohort into different numbers. This is all statistical modeling that's done by people certainly much smarter than myself, but you break it down into a training set, a validation set, and then you blind yourself and look at it in a test set and an independent cohort. And this is all to add layers of rigor to the analysis that you're doing to say that when you find something, if you find something, as Mary so clearly put it earlier, it's not up to statistical chance. This is actually a meaningful result. And I want to point out, like I said, that all of these patients were drawn pre-treatment, and we had patients with stage 4 disease. So when we did the statistical modeling, which is to say when we set out the question we were trying to answer, the question we were trying to answer was, can we use the signature to predict? So this is what I meant earlier by predictive biomarker. Can we use this signature to predict, very bluntly, who's going to live and who's going to die? And while that was the number that the way that we were modeling the data set, we actually broke down the data into 3 categories. What are the clinically meaningful categories? One is patients who just derive no benefit at all, what we call early treatment failure. 2 is patients who have intermediate control, meaning they have some benefit, but certainly not nearly as much as we would like. And then patients who have sustained control, the cases where the cancer is eradicated or controlled for at least 3 years. And what I want to show you here is by breaking down all of the glycopeptides, I'm just going to break it down for you by color, we were able to distinguish who is going to respond from who is not going to respond. And when we tested the actual performance of the model, asking ourselves, can we predict who is going to die with this disease? The answer thus far seems to be yes in this training, validation, and test sets. And when we took the signature and looked at it in a totally different population from a different continent to try and be as stringent as we could with the data, we looked at it in an independent set from patients from Australia, actually. The model still held up quite well. So this is really the very first step, certainly, in what's going to be a much longer story. So on the right-hand side here, you can see some of the key clinical trials of combination immunotherapy. When I say key, I mean phase 2 or phase 3, that certainly were on the radar of all of us in the field with major readouts that we were waiting on, many of which have led to approvals and many of which frankly have led to flops that were quite disappointing. What's missing across a lot of them is biomarkers. So you can see in the red, this is where I basically asked myself, did this trial have a biomarker? Was there a biomarker buy-in for the patients when they were going in? The answer, more often than not, is no, unfortunately. And so one of the many problems in our field right now, although certainly there's a lot of good, but one of the problems is that with so many clinical trials combining different drugs, different agents, different modalities, we need to be very thoughtful about this not being spaghetti on the wall. We need to have a very clear scientific rationale, a translational rationale. When I say that, I mean data coming from the lab to the clinic, from the patient to the lab, to tell us why we're combining A and B. We need to have a very good reason for doing so. And this is where biomarkers may come in. Historically speaking, we've really just looked at the tumor. That's where we started. But now we're understanding increasingly that we need to look at the tumor, that we need to look at the tumor microenvironment, meaning the tumor tissue and everything around it, everything within it. We need to look at the host, the patient. What's their microbiome, as we'll hear from Dr. Devar? What's their metabolism? That's a huge interest in my lab. What's their BMI doing to the tumor cell metabolism? What's in the peripheral blood? We need to put all of this together, ideally. I don't doubt that it's not going to be any one thing, to develop a robust predictive biomarker. And ideally, what we're all working towards is to understand all of these factors and tailor treatment accordingly to a patient's individual tumor characteristics, which certainly is not a stagnant thing. It's a very dynamic, moving target. The tumor is different, not just from a liver tumor to a lung tumor, but different regions of one liver tumor are absolutely different. There are different immune cells. There's different oxygenation. And so this is what you may have heard referred to as tumor heterogeneity. No two tumors are the same. No two parts of one tumor are the same. So you can see why this has proven to be such a complex task. So I'll finish where I started. Can we predict who will respond to immunotherapy? The short answer is not yet. But I didn't want to lead with that. I wanted to explain to you why I say that. Prognostic biomarkers, as I alluded to earlier, have declared themselves. We know liver mets are harder to treat than lung mets. We know brain mets are hardest of all. We know LDH that's very high is not a good thing. So we've learned just from having had the privilege of treating thousands of patients what the prognostic biomarkers are. We've learned about the disease. What's missing is to understand what biomarkers, what factors, if you will, can predict response. One thing that I had put in here, and I apologize, this PowerPoint didn't make it in with the 2 slides I wanted to add. One area of interest in my lab is looking at oxygenation or hypoxia in the tumor. And by understanding that, we actually think that hypoxia may be a predictive biomarker for a new kind of treatment. And so we developed this clinical trial that we have run here. We actually just finished enrolling it 2 weeks ago, combining medication that targets hypoxia with immunotherapy to try and overcome resistance of the tumor to immunotherapy. So that's an example, when I say translationally driven, lab-driven work, that's what I mean. Any biomarker that we come up with will need to be very robustly validated so that we are sufficiently confident when we tailor treatment decision-making. It needs to be ironclad. This is a hugely active area of research. I hope I've given you a flavor of that. And our results that I had shared with you show that this circulating glycoprotein signature, which is 14 glycoproteins, does appear to be related to overall survival, but I really don't want to make too much of this. It's very early days. And we are now working on writing the grant to prospectively prove this. So the first thing is you look back at a data set, you say, this looks interesting. And then you want to look at it prospectively to see if it's true or not. And so that's where we are. And so prospective studies are being planned. The last thing I'll say is I really just hope I imparted a very little bit of the flavor. I mean, this is certainly something we could talk about all weekend. And this is the very tip of the iceberg. And I'm sure there's a lot more to come.